Good afternoon, ladies and gentlemen. My name is Umut Akyol. I am an otorhinolaryngologist from Ankara, the capital of my country. This is Turkey, and I'm a professor in Hacettepe University Medical School. First of all, I should be reading you a couple of points from the second slide of mine. Please do not take any screenshots or reproduce any slides without written permission. The format is about 17-19 minutes of my talk, which will be about ENT manifestations of mucopolysaccharidosis. And of course, at the end, we shall have enough time for questions and answers. So please submit your questions at any time, any point. You have to text them, and I will read them and answer them if I can. And whenever you need to ask anything, please text it and ask a question. We'll appreciate that very much. We are recording this webinar, and it's going to be available, as you can see, on this address soon. So I told you that I am an ear, nose, and throat surgeon, an otorhinolaryngologist. Specifically, I'm a pediatric ENT surgeon. So I deal with pediatric patients all the time, and as you can imagine, most of them begin crying when they see me. But there are some who see me as a 5-star professor doctor, and this is very proud, of course, of me. And this is one of my best ever business cards made by a 5.5-year-old young lady, a patient of mine. So as I told you, I'll be talking about mucopolysaccharidosis and ear, nose, and throat, otorhinolaryngological manifestations. Of course, I'm not the one who will be, talking about mucopolysaccharidosis. I'm a surgeon. I'm a humble ENT surgeon, and I'm not a specialist in metabolic disorders. And there are much, better colleagues of mine that can talk about this subject. But we all know that mucopolysaccharidosis is a disease which is a malfunction of the enzymes that are metabolizing the glycosaminoglycans, the mucopolysaccharides, the old name which we're not using anymore. These glycosaminoglycans, GAGs, accumulate in the tissue all over the body, especially in head and neck and around ear, nose, and throat, and causes some serious problems. When they accumulate around the ear and the stationary peritubal areas, they cause the obstruction and serious ear problems, mainly frequent attacks of acute otitis media, fluid in the ear, otitis media with effusion, and hearing loss, which we have to take care. And when they accumulate around the pharyngeal areas, tonsils, adenoids, they cause obstruction, frequent upper respiratory tract infections, which eventually again need surgery. And not only, of course, the pharyngeal areas, these GAGs accumulate all around the airway, the lower parts too, and cause some serious problems with the airway, again necessitating surgery, which can be a very tricky point, as we will see. And these are the kids who have frequent attacks of upper respiratory tract infections very early in their lifespan. They have acute otitis media, as you can see here, otitis media with effusion causing some hearing loss. They have frequent attacks of pharyngeal tonsillitis with enlarged tonsils and adenoid tissue that is obstructing the nasal passage and causing some obstruction. These are the kids who have frequent attacks of respiratory tract very early from their lifespan. This is our own data from my own department, and as you can see, more than half of these kids that we are following for MPS has already undergone ear, nose, and throat surgery, TNA surgery, adenotonsillectomy, or putting tubes in their eardrums. And almost 2/3 of them had a kind of hearing loss. Almost half of them has harsh voices because of the GAGs accumulate in their larynx, in their vocal folds, and balance problems, almost 1/3, and almost all of them had accumulation in their mucosa and submucosal tissues that we can see in endoscopy with edematous and enlarged supraglottic structures, as you will see. And so why am I here? What an ENT surgeon can do about that? We are quite special about this situation because we are the ENT surgeons, we are the pediatric ENTs, we are the pediatricians that see these patients very early before they are diagnosed. And this is very important. We can help to diagnose these kids, but more important, diagnose them as early as possible, which is very important. And the second point is regarding the surgical treatment. We should be very careful because it's a dangerous area. And that's what we're going to talk about a little bit more. In MPS in general and Hunter's type 2 in especially, the difference of these kids are not, in general, not apparent at birth, but become noticeable after the first, second year of life. And since the symptoms of very frequent upper respiratory tract infections, for example, are quite common among all infants, they are not likely to lead a doctor to make a diagnosis of MPS right away. But this is important. We should, know what's wrong with these kids. Their appearances are different, as you will see here. There's a coarseness in the facial features, including a prominent forehead, a nose with a flattened bridge, and enlarged tongue obstructing the pharynx. And that's why, because all Hunters and MPS patients are look-alike, and they are a little bit different from the rest of the kids. Some patients, families, moms especially, were telling me that even from very early babyhood, they were a little bit different. They were not like me or my husband or their brothers and sisters. They were a little bit different. So keep in mind that these coarse facial features is something that we should notice. And more important, these are the kids, as you can see here, who have early, very early ear, nose, throat, and head and neck manifestations. And the median age of the diagnosis is about 3.5, 3.2 years, even in Europe. And before, much before this age, they come to us with frequent otitis media, frequent acute tonsillitis. These are the kids who come to you every second week, whom you have to prescribe antibiotics because of, bulging ears or draining ears. And they have quite frequent attacks, more than usual frequent attacks of upper respiratory tract infections. Plus, what is very important for Hunters is they have abdominal hernia. And if you can keep in your mind that frequent attacks of respiratory tract infections very early in their lifetime, plus hernia, or history of hernia repairing surgery, or history of ear, nose, and throat surgery, keep in mind that this can be a Hunter's kid, for example. And this is how we can diagnose these kids early, very early, because if we can diagnose these kids early enough, they will have a longer, healthier life with a much better quality of life, of course, not only for themselves, but for their families and for the society as well. That's why it's very important to diagnose them as early as possible and to control the disease, even if we cannot cure it. And we are the ones who can do it if we just know these couple of points, 2 points that I have already talked about. And ENT examination shows the GAG accumulation all around the ENT. The otoscopy is more or less similar to the rest of the kids, but most of the time you can see the bulging eardrum due to acute otitis media or otitis media with diffusion of the dull drum. The nose is almost always narrow with enlarged turbinates. This is kind of obstructing the nasal passages. Throat, especially when the disease progresses, is very hard to see because of the enlarged tongue, as well as the tonsils and adenoid tissue, and also the gums and the mandible and the teeth that is growing and obstructing the entrance of the pharynx. They always have a short neck and limited movement of the jaw, and the neck will improve by the progression of the disease and cause some serious problems. Flexible endoscopy is a very useful tool for us that we use all the time in these kids, whenever we see them for diagnosis and for progression and for follow-up. And this is a little baby, and this is the endoscopy. This is the nasal passages. You see the enlarged turbinates, and this is adenoid tissue, as you can see, filling the nasopharynx and obstructing the nose. This is whitish. The accumulation of GAG makes it edematous. And you see the larynx and the supraglottic tissues, especially the arytenoids and aryepiglottic folds. The mucosa is here also swollen. It is whitish. The accumulation of the GAG is kind of obstructing the inlet of the larynx. And this is a typical, and this is the eardrum, as you can see, quite dull, whitish, not semi-transparent anymore. And this shows the flute. in the ear, and this is otitis media with diffusion, and this causes, of course, hearing loss, which is very important in a little baby and kids for all the cognitive behaviors that will be, coming in time. And that's why we use flexible endoscopy all the time. And because of these obstruction, because of this narrowing of the ear, nose, and throat, all of these kids have a kind of obstructive sleep apnea. The obstructive sleep apnea is quite important in the rest of the kids, but MPS patients are high-risk patients for obstructive sleep apnea syndrome. And they should be diagnosed earlier, they should be treated earlier, and more than half, almost 3/4 of the kids have obstructive sleep apnea syndrome, or the OSAS kids. We know that when a kid has obstructive sleep apnea syndrome, the treatment is straightforward. Surgery, adenotonsillectomy is efficient in most of the kids, almost 80%. But we should be keeping in mind that MPS patients are special, and surgery can be a real catastrophe in these kids, as you will see. We should be very careful about the surgical treatment. We should be, putting tubes in these kids, doing adenotonsillectomies or any other kind of surgery, orthopedic surgery, neurosurgery. But these kids, when they go to theater, to the operating room, can be very dangerous because of high rates of complications and serious morbidity and mortality. And this is a very unfortunate patient of us who taught us a lot about MPS patients and these complications and mortality in MPS patients due to surgery. She was a 10-year-old female patient, unfortunately with very advanced disease, where all the morphological changes took place and obstruction everywhere, not only in head and neck area, but craniofacial and vertebral anomalies, kyphosis, vertebral bodies all over, and with very low pulmonary function. And she had critical OSAS with very high rates of apnea index. So she was decided to have adenotonsillectomy, in fact, taken into the operating room, but a senior anesthesiologist at that time refused to put her into sleep. She said it is quite dangerous and we should do something else. Well, she was sent back to the ward, and then wrong decisions followed each other. The kid got more and more serious with real obstruction. A month after the first attempt, the chief resident of us at that time took the same girl again into the operating room. They put her into sleep, did the adenotonsillectomy, and as expected, every single complication occurred, followed each other. They had to open a tracheotomy and put her into the ICU, but unfortunately, we lost her in the second postoperative day in the ICU. And that really taught us a lot and made us think about that. And it is really very dangerous to keep an airway or open an airway in these kids during any surgery, let alone the pharyngeal or airway surgery. And can you imagine a kid like this without extension of the neck any millimeters, or even try to open a tracheotomy in a kid like this with a incredible narrow space of neck, or put a child like this into supine position? It's not possible at all. So once the disease progresses, this is really, really dangerous. Even if you can intubate this kid, can you see this trachea that is deviated, narrowed, and you cannot extubate this kid. So perioperative and postoperative complications are very, very high. The rate of complications are very high on these patients. So we should keep this in our mind. These are dangerous. That's why I'm calling them dangerous patients for us, not only for us, for the anesthesiology. And we have quite a dilemma here. On one hand, we should be operating these kids because they are the ones who are suffering a lot. They are the ones who have indications for any kind of operation. They are the ones, high-risk ones, who needs operation as soon as possible. And on the other hand, they are the ones that we don't want to operate because we know that they have high complication rates, including serious morbidity and mortality rate. And there should be a solution. And what the point that we have reached, at least I have reached, and what I'm trying to do at the moment, and what I would advise you to do is first, if you are going to operate on these kids, if you are going to do any kind of surgery, try to do it as soon as possible after the diagnosis, before the disease progresses and serious morphological changes took place and irreversible changes are there. Because once this disease progression happens and this morphology changes and the airway narrows, it is really hard to do any kind of surgery. So if you have an indication, do not wait. Do the operation as soon as possible. And the most important point is, the second point, remember that this is a multidisciplinary team effort. Pre-op consultations with anesthesiology, ICU specialists, metabolic specialists, orthopedics, neurosurgery, pulmonology, all should be done in a team. The team must probably be led by a metabolic disorder specialist. And for me, the most important ones in the team are the anesthesiologist. You should have a very experienced anesthesiologist, what she knows she's or he's doing, and in terms of complications, you should rely on them. And the second is ICU people, because these kids have to be taken to ICU after the operation. The perioperative and post-op complications are very important in these kids, so we have to keep them in a very well ICU with experienced colleagues working there. And this is how we can deal with complications in my case. And let me repeat again the take-home messages that I want to give to you today. We are the ones who can diagnose these kids as early as possible because we see them. We should keep in our mind the different course features of the face, that they have frequent attacks of upper respiratory tract infections very early in their lifespan, that they have other features like hernia or hernia surgery when they were little babies. We can keep this in our minds and diagnose them and help them diagnose them. We can send them to metabolic disorder colleagues of us. And the second thing is surgical treatment can be dangerous with high rates of complications on these kids. We should be operating them as early as possible if we have to, and in a team. If you do not have a good ICU, dependable colleagues on emergencies, in the operating room, theaters, anesthesiologists especially, send them to a tertiary center. Do not do it alone. And thank you very much for your kind attention. This is another picture of my patients. This is me, by the way. And now it is time for the questions and answers. You can still, send your questions, text your questions. I'll be very happy to answer them if I can. And first of all, I should be reading the questions. Okay, is endoscopy needed? Frequent endoscopy is needed on these kids, and what kind of? Okay. As an ENT surgeon, as a pediatric ENT, I should be monitoring these kids' airway before and after the operation. And the easiest way to do is, or the only way to do is this flexible endoscopy that I showed you. I do flexible endoscopy every time I see these kids, every time I see normal kids too. And it's an easy procedure. It doesn't need any kind of precautions. It can be done anywhere. It's only 30 seconds of your time. And we can talk a lot about that. But flexible endoscopy for diagnosis and following up of these kids are very, very important. And let's see whether we have some more questions. Okay, when do these patients need hearing aids, or do they need hearing aids? Well, as I told you, and as I have shown you, most of these kids have hearing loss. In the early phases, because of the fluid in the ear, otitis media with effusion, and later in their lifespan, most of them have sensorineural or mixed type hearing loss too. And that's due to GAGs accumulated in the inner ear. And so they need a way to improve their hearing. That's why we put tubes, ventilation tubes on their eardrums. This is an easier procedure. This can be done under mask anesthesia if the kid is not really advanced, doesn't have advanced disease. And that's what we do it. And I prefer to put long-term tubes, not T-tubes, but larger Paparella type tubes on them for them to stay longer. And of course, if the hearing gets worse and if the mixed or sensorineural type of hearing appears, then they need hearing aids because they cannot hear. When they cannot hear, everything goes much worse, and that they certainly need hearing aids, sometimes very early in their lifespan. the adult ones, most of them need. Okay, let's take a look at another ventilation tubes. Yeah, I have already talked about that. I prefer the Paparella type 2 large ventilation tubes that will stay there for a quite longer time. And this will help for them to hear much better for a longer time. Do these children have the same facial appearance at birth, or their facial features become more evident while they are growing up? Meaning, can we diagnose the no at birth? This was the question, sorry. Unfortunately, as I told and as I have been talking during my talk, during the very early babyhood, they are more or like same with the rest of the kids. Of course, there can be, you know, differences, nuances are always there. Some are worse, some are much better. But if you are not really knowing what you're looking at, if you don't see much MPS patients, and you may not notice. So that's why the median diagnosis time is more than 3 years of age. But if you know an MPS patient, if you know the features that I was talking about, you can catch them 1 year old, 1.5 years old, 6 months old. And some parents, they know that there's something wrong with the kid. They are different, but most of the time they don't want to confess them to themselves even, because they don't want their little kids to be ill and sick. And that's why knowing the disease, keeping in mind the features is very important to diagnose these kids. Unfortunately, not possible at birth by just looking at them. Okay, let's see another question. What the certain age for adenidectomy, tonsillectomy? Very good question. No age limitation here. Whenever they need surgery, whenever there's an indication, there is frequent attacks of adenotonsillitis, more than 5 in a year, or enlargement of the tonsils and adenoids causing sleeping disturbance and obstructive sleep apnea syndrome, especially, they need to go under surgery. There's no age limitation for me. I can do it in 6 months old, a year old, 3 months old. I have done adenidectomies on a 6 weeks old baby because he wasn't, you know, breathing at all. It was something else. But no, there's no age limitation. Whenever they are they have the indication, go on and do the surgery. And that's what I do. Okay, when is appropriate age to do adenoid surgery for a patient with, this is the same question, I'm so sorry again, from another colleague of mine. Anytime. If the indication is there, do the surgery. That's what I do. Are you aware of any algorithm based on signs and symptoms that will help us to diagnose MPS patients as early as possible? Well, the very simple one is the one that I told you about, Hunter, MPS 2, is if you have a patient with frequent attacks of upper respiratory infections, early, plus hernia, any kind of hernia or surgery or history of surgery, then go on and send this kid to metabolic disease disorder colleagues of us so that they can test the kid. And there's quite a good possibility of him or her be having, you know, Hunter's, even him, even her. And but other than that, different MPS patients have different features, of course, but in general, what I have been talking is more or less can be taken as a algorithm. If you sense something wrong in terms of the appearance, the points that we have been talking about, then it's a good reason for you to send these kids to screening. Screening may not be the right word, but I'm an ENT surgeon. I don't know about, you know, I'm not a metabolic disorder specialist. I'm not a pediatrician. Okay. The enzyme replace therapy changed the course of severe obstruction problem that sometimes need tracheotomy. A very good question. I told you I'm not the one to answer this question. I'm an ENT surgeon, but it helps. Yes, we cannot really talk about cure. Especially in some forms, there's no, in some forms we can control the disease, but controlling the disease, we have enough data now. think they have that now, that enzyme replacement therapy, controlling the disease, help us, the ear, nose, and throat surgeons, to keep the kid without tracheotomy for a much longer time, sometimes without any tracheotomies needed. But this is a progressive disease. Some of them progress faster, some of them not as fast as the others. But if the disease progresses, we have to do it. And any kind of therapy that will, stop this, we should try. And again, I'm not the one who are treating these kids with, who are treating these patients with enzyme replacement therapy, but I know that it helps. Of course, a better answer can be gotten from the metabolic disorder, pediatric metabolic disorder specialist friends of us. After how many episodes of acute adenitis should we consider the surgical option in these children? The main thing regarding the adenoid tissue is the enlargement and obstruction. Most of them, when it is large enough to obstruct the back of the nose, they have chronic infection there too, with draining, postnasal kids they are. So the adenoiditis, the infections, of course, is important. Just like the pharyngotonsillitis, more than 4 or 5 attacks a year is an indication for me. But 90%, 95% of the kids that we operate, the indication is not the infection itself alone, but the obstruction. So if they cannot breathe from their nose, if they have sleeping disorder, if they have apnea, this is an indication. I don't want to wait for attacks of infection if they are obstructed. And do you do tonsillectomy and adenidectomy preventively when you know the diagnosis? No. I mean, if I see an NPS patient without any sleep disorder or enlargement of the tonsils and adenoids, no frequent attacks of adenotonsillitis or no chronic discharge or back nasal drip, I don't do the operation. I do the operation when it is indicated. The indications were there, as I told you, frequent attacks, obstruction, of course, many more. But these two are the main important indications for us to operate a kid, adenotonsillectomy. If they do not have any indication, no, I won't go and operate them preventively. But if they have the indication, I do not want to wait for a couple of more months using some topical steroids or more antibiotics. If I have the indication, I will go on and operate them as soon as possible before the disease progresses. That was a good question, thank you. And another question, let me see. Is the difference between intubation of children treated with ERT and without ERT? If the disease has already progressed and morphological changes, irreversible changes took place, no. Whether they are under ERT treatment or not, the airway is dangerous, it's very hard to intubate and harder to extubate. And that's why, I'm telling you that don't wait for the disease to progress into irreversible phases where the morphological changes all over the airway and is there and will be there without any returning. And that's why we have to catch these kids as early as possible, begin treating them as early as possible, so that we can take care of them more easily without many complications. But after that, no. Okay, are there any more questions? Let me see. No more questions. Okay, and I think that's it. And thank you very much again for listening to me. If you need to reach me, you have my email address here, and I'll be very happy to answer any questions. Thank you very much for listening to me this afternoon, and I wish you a very, very good day. I'm closing the session now. Our webinar is ended. Thanks again. Bye-bye.